Heart Month. Pleased to be giving a talk on matters of the heart, because heart does matter, as you all know. Before I start, I'd like to thank Judy for arranging this and the rest of the marketing team. I would also very quickly like to acknowledge a few people. Alana, as head of the department, I think she's done a wonderful job. Not having a cardiology background, I think she really did wonders in recruiting new staff and also keeping the ship afloat in very difficult times. Also, as you know, cardiac rehab is now open again, and there was a lot of her effort, along with the support from CEO Irene and the chief nursing officer and all the rest of the administration team to get us back in business. And I'm sure you all like that. I know you all like that. My ECHO team, which is the backbone of our department, Barbara and Rashid, our secretary, which is literally my right hand, Norma. And I can't forget Virgie, even though she's not with us in day to day, but her efforts and her work over the decades is what has been so useful and helpful to many of you who are in attendance. So without any further ado, let me dig right into the topic. As you know, heart disease is still the #1 killer. And 1 out of 4 of all deaths occur because of heart disease. And some of the numbers are really staggering. And that's why I think it's important. The preventive services are so important, because some of this is avoidable. Hypertension, almost every other person in America is hypertensive. Over 100 million people have hypertension. And some of that, much of it, is really not under control. So even half of the people who have hypertension don't have it, and the ones who have it and know it are not adequately treated. Congestive heart failure is #1 diagnosis in the hospitalized patients. Coronary artery disease, 18 million people in America have coronary artery disease. Almost 1 million heart attacks occur every year. But I repeat that even though these numbers are scary, there's something that can be done about it. And that's my task today, to educate you a little bit about how the heart works, and sometimes it doesn't work, and what we can do about it towards the end. So this slide, if you can see that, all of you, like I mentioned, coronary artery disease is one of the commonest problem in heart diseases, and heart failure is right next to it. Some of the other things that are listed here, I'm not going to necessarily talk about it unless you people have questions or somebody has a specific thing to ask. But heart valve disease, arrhythmias, heart muscle disease, people are born with some of the heart diseases. That's not my main topic today. I'm going to dwell mostly on what's the commonest problems. Before I go on with the main part of the presentation, I want to spend a few minutes on COVID and heart disease, and unfortunately, that's something that no talk today, or no topic, no discussion is complete without really having to deal a little bit about the issues of the COVID. You could easily take a whole hour about COVID and heart, and that's not my intention. But I just want to make a couple of observations. And one of them is that people who do have heart disease, when they get COVID, it's a more serious disease. And their chance of getting the serious disease and some of them even dying from it is at least twice as much as the people without heart disease. So that's one thing. And the other is that COVID itself can affect the heart in several ways. One of them is directly involving the heart muscle, getting it inflamed. The thin layer around the heart muscle, that's called pericardium. People can get pericarditis, and they can weaken the heart, they can enlarge the heart, they can cause arrhythmias. So fortunately, it's rare, but it's possible, and that's something that we have to look for in sick COVID patients when they are hospitalized. And the other thing is that COVID can have a bearing on heart disease by affecting the blood pressure, by affecting the oxygenation. And of course, people with already compromised cardiovascular system will be more likely to get heart attacks and heart failure precipitation. And one of the other things that I really would like to share with you, even though COVID can directly affect the heart and indirectly can affect the heart, but perhaps its main impact has been by preventing people from seeking help for the heart problem. In the beginning of the pandemic, a little more than a year ago, or almost 2 years ago by now, we noticed that our procedures in the cath lab were down, people showing up in the emergency room, and there was no good explanation at that time. It turned out that people sat at home and literally were deathly afraid to come to the emergency room to seek help. And unfortunately, there were some deaths because of that. So as much as we are afraid to go into the hospital, if there is a need for it, we should not do it to a fault. And I think that that's been, by now it's very well recognized that perhaps the main impact or the biggest impact of COVID has been in scaring people from going and seeking help. And it's not just the heart disease, people are not seeking help for other diseases as well. And that's not smart. When you need to, you have to come to the hospital. And even though, and hopefully it's the beginning of the end of this pandemic, and I think things are looking significantly better as we go from January to February and towards the March and the rest of the year, they're predicting that in a couple more months, perhaps we will have a major decrease in the incidence of this disease, and I hope they're right. But as many scary things that have occurred because of COVID, I want to share with you a couple of good things that have also come to surface. I think we have recognized that equity of healthcare is very important, that we cannot vaccinate just a portion of the population and expect this thing to go away. I think we have to do it globally. And the other thing that it has also brought to surface is the very intense and fierce campaign to develop the vaccine. And as some of you may be aware, the Pfizer and Moderna vaccine is a totally new health and pharmaceutical pathway, the messenger RNA technology. And now that technology is going to be used for treating heart patients, cancer patients, and autoimmune diseases. So it has ushered in a whole new area of pharmaceutical developments that may not have been possible without all the experimentation that took place in combating this disease. I want to talk a few words about congestive heart failure, and for short, it's called CHF. That's when the heart is unable to pump enough blood to the rest of the body and to oxygenate the rest of the body. It occurs either because of a weakness in the heart muscle, or when the heart does not sufficiently fill itself. And we have fancy words for systolic and diastolic, but that's not so important. They both can be deadly, have a lot of issues and problems. And just very briefly, this picture shows you some of the symptoms of heart failure. This person cannot breathe enough. This person has swelling on the lower extremities, feeling fatigue, not being able to do your work, sleepiness, weight gain, which is because of the water retention. All of that can occur because the heart is weak and the heart muscle is weak, and that can result from either having had a previous heart attack or direct involvement of the muscle itself. I think I'll skip this slide because we're going to talk about the risk factors a little bit later, so it's just a duplication. Treatment options for heart failure are fortunately numerous. And again, this is a kind of busy slide, and many of you are on the medication. I've only listed class of medications here, like ACE inhibitors. These are drugs like lisinopril, enalapril, captopril. They all the drugs that rhyme like that. One of the major developments from the 80s and 90s, and very good medication for blood pressure control as well as the heart failure. Angiotensin receptor blockers, losartan, olmesartan, irbesartan, a lot of drugs that I'm sure many of the patients who are in attendance today may be on these medications. Beta blockers are another major class of drugs that also are used for control of blood pressure, for heart failure, for heart protection, and even the arrhythmias. These are drugs that for example, metoprolol is perhaps the most widely used, but propranolol, Pindolol, and some of the other drugs that rhyme like that. And diuretics, which many of you call water pill, and just about everybody hates it because it makes you go to the bathroom rather quickly. But they are important. They are important. That's how you get rid of the swelling. They make the breathing better and decrease weight. So there's a place for it, and it's very important when it's necessary. If some of you have specific questions about some of these medications, I can get into more detail, but suffice it to say that there has been major developments, and there are some newer medications that are already being used, like Entresto, and there are more medications on the horizon that are just on the verge of being approved. So there's always, this is a continuum, this is a fluid, this is the pharmaceutical industry is very, very responsive to the needs of the patients and making things easier, better once a day. My only, if I can mention that as a side, is the cost of the medication, and some of the newer ones, especially. I wish we could do something about that, but fortunately, insurances sooner or later will get on board and approve these things, and hopefully the out-of-pocket cost will not be too much, even for the newer medications. There are several devices and procedures that can be done for heart failure. One is called a defibrillator that takes care of the erratic heart rhythm when it occurs. And there's something called assist devices, that the heart muscle gets so flabby, so weak that it needs support of a pump, and that pump can now be implanted inside the heart, and it can stay inside the heart for several years, believe it or not. Some of you remember, 20, 30 years ago, the first artificial heart, which was a huge device that sat outside the body and had to be connected to the battery all the time. These things are now, they have their own power source that periodically needs to be replenished, but they are all inside the heart muscle, and they can provide significant support. And if nothing works, then heart transplantation is still an option, and fortunately, that is a good option. People who get a new heart, they really almost become like new. Unfortunately, there are not enough donors, and some of you may have heard that they did the first transplant from a pig after changing the some of the minor immune functioning of the heart so that it is not rejected by the recipient. You'll hear more about that, I think, and it's not just sci-fi. I think it's going to be a reality that sooner or later they're going to be building organs as well, like a 3D printer making a kidney, making heart muscle, making other organs, and that may become a reality in our lifetime. I want to spend a few minutes on coronary artery disease issues, what's called a heart attack. In this picture, you have a blood vessel that we call coronary artery that is on the surface of the heart muscle. The blackened area that shows here is a damage that occurs because of a blockage in that coronary artery. And that blockage has to do with long-standing high blood pressure, cholesterol buildup, and several other factors. We'll talk towards the end of the talk about what the preventive efforts that we can take. If that does happen, usually it presents with chest pain. And this is, again, a busy slide, so don't stare at it too much. I want to very briefly mention that even though everybody talks about chest pain, there are some things that you need to know about symptoms of heart attack. One is that, in fact, it may not be pain, but it may be more like pressure or difficulty in breathing, or what people call choking sensation, or gripping sensation, or elephant on my chest. So it may not be actual pain, but it's a feeling of pressure and heaviness. The other thing is that the location may not be always chest, and it may be neck, it may be jaw, it may be arm, it may be a little finger. But if it's anything that occurs with exertion, then it's bothersome, and it should be attended to. I think that the two messages that I want to convey to you, it may not be always pain. And some people, in fact, women have very atypical presentation that there may be nausea or vomiting or indigestion or GERD-like symptoms. So I think any new symptom that is attended with difficulty breathing, choking, heaviness should be attended to, and you seek help. What do you usually do? How do you respond to a heart attack? You chew an aspirin, take nitroglycerin under the tongue, and call 911. I think if you seriously think that there may be something brewing and it is a new symptom and it feels significant, it woke you up in the middle of the night, or it's something that's not easily going away, I think the worst thing you can do is drive yourself to the hospital. I think seeking help at that point and calling the ambulance, it's very, because the ambulance not only it facilitates and makes it easy for the trip to the hospital, but they can do some treatment on site. These are very trained, very sharp people who can initiate treatment that you will obviously not be able to do it on your own. And I think that the other message that I want to convey to you is if you really think there's something seriously brewing, Don't sit on too long. Maybe it'll go away. Maybe I'll watch for another half an hour. Maybe because in our community, in cardiology community, we say time is muscle. If you every minute counts, and the later that you show up in the hospital, the less benefit you get from the angiogram and opening up the artery. So sooner the better. If it's a false alarm, so be it. It's not the end of the world that you came to the hospital and everything checked out okay. Obviously, you don't want to keep doing that every so often, but unusual new symptomatology, don't ignore it. When you do get to the hospital, there are two things that the emergency room will do right away, other than to put you on oxygen and start an IV. They will get an EKG. And many times the ambulance people actually have gotten the EKG and a good quality EKG in the ambulance, or even at your home. And they beam it to the hospital, to the doctor, and even to a cardiologist. I sometimes receive an intimation that there's a heart attack on the way, and here's the EKG, confirm it, and get things going. So the efforts to mobilize and get to the hospital fast, that's the name of the game in this when it comes to heart attack. The other thing they do is get a blood test which confirms if what we call troponin, if it is elevated, it confirms that indeed we're dealing with a heart attack. Some of the other things that are done, not always, but usually, one is an echocardiogram, which is an ultrasound of the heart, and it has a ton of information. It's non-invasive, doesn't require an intravenous, does not require any additional drugs or any harmful. So far, nobody has come up with anything bad about ultrasound, at least in the quantity that's used for heart testing. But it looks at the heart muscle, it looks at the heart chambers, it looks at heart valves, and all of that information is very, very useful to the cardiologist. Sometimes when things are not that obvious, the blood test is questionable, the EKG is questionable, then we may do a stress test. And many of these stress tests are combined with nuclear imaging or echo imaging. And I don't want to get into too much of the detail, but some of you or many of you may have undergone this. You either walk on the treadmill, or you get a medicine that mimics the exercise, and these are medicines that cause vasodilatation or dilatation of the coronary arteries to get more blood into them. And then you compare before and after the medicine with nuclear images to see if there is any issue or problem. The ultimate test perhaps is the cardiac cath. It's also called angiogram. This is a picture of our cath lab. Many of you may have had it when it's necessary. I kind of say that it's not a big deal because it does require a needle puncture and dye, and sometimes the dye is of some concern for especially for kidney patients. But the information that you get cannot be obtained from any other test. It lays out the roadmap of the coronary arteries. It identifies the blockage, and then you can go and open it up and leave a stent. The next slide will show you how it's done. You have a wire in one of the arteries. You see a little blockage at the site, right by the arrow, and you inflate the balloon, open it up, and then you leave this wire mesh in there to keep it open. That's called a stent. And this has become the standard procedure for over 10 years now. Anybody who has a heart attack, we leave everything and run to the hospital, get the patient into the cath lab, do the angiogram, find the blockage, blow up the balloon, and open it up and leave the stent. The entire process, we like to finish it within 90 minutes. That has become the benchmark. That's what we are striving for. And believe it or not, most of the time meeting that. But I repeat again, I think I mentioned it earlier and I repeat again, a good part of this whole effort is in your hands. If the patient shows up late in the emergency room because you sat at home and waited for the problem to go away, then we have lost a very important time that we could have utilized to open the artery earlier. But we do whatever we can do best on our part. The risk factors that I said earlier that there are some preventive efforts and some things that we have no control over. That's why I listed, things that you can't control age. The coronary artery disease is a problem of aging. Obviously, a 20, 30-year-old will be a lot less likely to have heart disease than a 60, 70, or 80-year-old. Male they are a little bit more prone, but by no means. I would almost take the gender out, honestly, because women are only about 5 to 10 years behind men in terms of catching up for their risk of heart disease. I see a lot of female patients who also have coronary artery disease. I don't want to give you the impression that this affects only the men, that heart attacks only occur in men. I think that at some point there was a wrong notion. People thought that heart disease was a lot more common in men, but I think that may be true in younger patients because the estrogen has some protective effect on the heart, but after menopause, all bets are off. Women are just as likely to have heart disease as men. If you have a strong family history, somebody has died or has had a heart attack in the family, especially at a young age, in 50s, 60s, that's a very strong predictor that you might get heart disease also. And the African American, Mexican American, American Indian, some of the race, ethnicity may have something to do with making you more prone to heart problem also. This is my more favorite slide because these are risk factors that you can do something about. And smoking, there's no question, it doubles or triples your risk of developing coronary artery disease. Sedentary habit is a major risk factor. Saturated animal fat, high cholesterol food is a major factor in causing heart disease. Overweight, obesity, diabetes. Some people feel that if you are a diabetic, that it should be assumed that you have some coronary artery disease. Blood pressure, major risk factor, both systolic and diastolic. And stress, even though it's hard to measure, you have a number on blood pressure, you got 140/80, you got 130 or 170. But how do you measure stress? But that also is a major factor in causing heart disease and precipitating heart disease. So the road rage and depression and feeling of hopelessness, these things are very, very contributory to precipitation of heart problem. Exercise is probably one of the best preventive efforts that you can utilize. And in a very simplistic way, I would say there's absolutely nobody who should not be able to exercise. People who have had heart disease, people who have had heart failure, people who have had stents, people who have had pacemakers. There's no contraindication to exercise in just about anybody. Now, of course, everybody cannot run a marathon, so everybody's expectation, everybody's level of exercise is going to have to vary according to their age, according to their disease. But the point is, just because you are labeled with certain heart problem or other problems does not make you not able to join an access program. And that's why we so proudly talk about cardiac rehab. I've been fortunately attached with this program for 30 plus years, and we take a lot of pride, and like I said, so good to have reopened the program. But again, I mentioned it. You don't have to come to the facility. You don't have to have a structured program to benefit from exercise. It can be done at home. It can be done in a gym, depending on your condition. I think the role of cardiac rehab, that in the beginning, they monitor you, they check your blood pressure, they check your ECG, and prod you along and get you back in your pre-disease state, and then a lot better with time. So over time, with structured exercise program, your ability to be able to do physical work will definitely improve. I'm sure that's why many of you are in attendance. They can attest to that. I know many of you came back to the program very gladly, and I'm also glad to have been able to reopen this facility. But it's more than just the exercise. It's an educational part. There's support. There's camaraderie, friendship, comparing notes about your illness with each other. There are talks from dietitians, from pharmacists, and all of that makes it a comprehensive overall useful program. You want me to click on?
Yes.
I will open it to questions now, and I'm sure we still have good solid 10, 15, 20 minutes that we can kind of chat one-on-one. Do we have any questions, Judy, so far?
No one said anything. Just
Yeah, you have to unmute, and can they also send it by text or
oh, yes.
email?
Mm-hmm. By chat?
No.
They can put it in chat.
Yeah.
Sure.
Hi, my name is Young Classic. I have a question.
Uh-huh.
Can you hear me?
Yes.
I got an email from someone. It says if you're alone and if you think you have a heart attack, and what can you do before you call 911 and help comes, or if you're driving before you get to the ER, it says you can help yourself by coughing repeatedly and very vigorously. And a deep breath should be taken before each cough. And the cough must be deep and prolonged.
Yeah, I got your question. I think it's smart. We call that poor man's resuscitation. So if you take a deep breath and then cough, it is as if you are massaging the heart. So it can increase the blood pressure if the blood pressure is dropping. This is helpful in, God forbid, real large MIs or heart attacks. And if the person is about to collapse, this may prevent that. So yes, I agree with all of what you said. It is a means of resuscitation, self-resuscitation, if you will.
Okay, thank you for confirming it. Before I refer to someone else, I wanted to get validation from a cardiologist.
So my pleasure, and thanks for bringing it up.
Thank you.
Dr. Sheikh, I have a question.
Yes.
What does chewing and aspirin actually do for your body?
Yeah, aspirin is a blood thinner, and the idea of chewing instead of swallowing is that it just works faster. So you chew the aspirin, it will get into the bloodstream probably 10 times faster than if you swallowed it. Because absorption from the mouth directly, broken tablet, chewed up tablet is much faster than it will through the stomach.
Okay, I have a question, another question in
Uh-huh.
chat.
Uh-huh.
The question is, after the blockage and stent inserted, with exercise and diet, can a realistic goal be to reduce or eliminate some of the medications you were taking?
It's possible. In the beginning, obviously, you will be on what we call the beta blocker, metoprolol, aspirin, and another blood thinner called clopidogrel or Plavix or Brilinta in some cases. Those blood thinners, after 6 months to a year, we stop them many times. In some situation, depending on the situation, we may continue. But metoprolol dose can be reduced, and some of the other medication for the blood pressure may be reduced, because regular structured exercise program will lower your blood pressure, will improve your lipid profile in the body, will decrease weight, will improve your sugar and diabetes control. And in addition, it also improves the attitude, the mood, the well-being. So yes, a lot of the antihypertensive, the beta blockers, the antidepressants, they may, many of those could be weaned off.
This might be a
Mhm.
silly question, but the development of blood clots and heart attack and heart disease, how does that play into one another? Is there any correlation?
Yeah, of course. So it's a very good question. In fact, I didn't dwell on it too much, but how does the clot develop? How does the artery get blocked? So it starts out with a partial blockage, which is the fatty deposit and scarring from long-standing hypertension or smoking, because they damage the inner lining of the coronary arteries. And then there's the precipitating event, which is the formation of the clot. And that can be induced by an injury to that plaque, the partial blockage, the little lump that forms inside the artery may undergo partial rupture. And once that surface is exposed, the body immediately works to form a clot. That's body's response. I mean, ordinarily it's meant to be good. You get an injury on the surface of the skin, and like you cut yourself while shaving, and 5 minutes later there's a clot formation and the bleeding stops. So inside the coronary artery, the body thinks that there has been an injury and it needs to stop the bleeding. But in this case, obviously, it works against the body, against the health, because that clot then makes a partial blockage into a complete blockage. And now it requires either blood thinners and or a needle and a balloon and a stent to open it up back again.
Here's another question. Thank you, Dr. Sheikh.
Sure.
When do you make the decision to put in an ICD for heart failure patients?
Usually it depends on the strength of the heart muscle. So if we measure something that's called ejection fraction. This is the percentage of the blood that is ejected out, excuse me, with each beat. Normal is 60 or above. When it drops 30 or below, that's an indication for ICD. Not that when that beating power of the heart reduces by half or lower, you become very susceptible to arrhythmias and an erratic rhythm that can literally kill you. That's sudden death. You're preventing sudden death by putting an ICD, and that's indicated when the heart function is less than half.
Another question. Is dark chocolate really helpful?
Happy belated Valentine's Day, guys. I think coffee and chocolate has some beneficial effects, and at least let me say this: nobody has found anything harmful about these two products, and there are some studies that show that your cognition may improve, that blood flow in the coronary arteries may improve. So yeah, I would cautiously say that it does have some advantages. Let me be quick to caution you that the sugar that goes along with the dark chocolate is not at all good. So I don't know what the option is, whether the sugar can be eliminated or reduced, or sugarless chocolate. It's yeah, the sugar part is the problem. But otherwise, yeah, chocolate and coffee are actually good for heart.
I have a question.
Yep.
If
Yeah, I
you
can-
have, if you have a leaky heart valve, do you usually need a valve replacement?
That's a good question. And like I said in the beginning of the talk, that I was going to mainly dwell on heart attacks and heart failure, and I didn't talk much about the valves. But leaky valves are common. Leaky valves, there's a whole spectrum from like almost borderline normal to all the way to severe. So obviously for borderline or mild or moderate, you don't need valve replacement. But if it is severe, you might. And there are very, out of total population, or let's say if you took 100 people with leaky valves, only 1 or 2 are going to have severe form. Majority, and at least 90%, will have mild to moderate, and they don't require a valve replacement. So even though at first blush it may be a little scary thing, but it doesn't have to be. And then there are medications that can also be useful for the condition. Any other question?
I'd like to make a comment.
Yep.
I'd like to just emphasize that symptoms that are unfamiliar to your body, that are abrupt, that you should all take caution and maybe make a doctor's appointment, talk about that symptom to identify what can be off. I noticed last year we had someone who was experiencing pain in her shoulder, along her arm, her upper arm, all weekend. And she came into her doctor because it was just an uncomfortable, unfamiliar feeling for her. And indeed, she had blockage.
I think I couldn't agree more. I hope everybody heard Judy's comment, and that is so important. I think it's a good comment to end this talk on, which is abrupt and unusual, and something that is not used to. I mean, obviously, when I say get to the hospital fast, and you can't sit at home with these things, and don't take it upon yourself to self-treat. But at the same time, you don't want to be running to the emergency room every day or every so often. So how do you decide what is important, what's not? And I think this is that's why I say it's worth repeating what Judy just said. Abrupt and unusual, and something that you're not used to, that needs attention. That needs doctor's appointment. That needs emergency visit if necessary. So don't ignore that.
Another question came in.
Yeah.
When you exercise, how high should your heart, what is the acceptable heart rate when exercising?
So this is the concept of exercise prescription, and I get involved with that to some extent with our nurse and exercise physiologist. And if you have a stress test and you know what kind of heart rate you got up to, we like to stay about 70 to 85% of that maximum heart rate achieved by that person. If you have not done a stress test prior to enrollment in cardiac rehab, then generally we say resting heart rate plus 20 to 30 beats. We'd like not to exceed 120 in most people because that's more than enough. Many people are on beta blockers that limits the heart rate. So rather than be fixated on any kind of fixed heart rate, I think it's resting plus 20 to 30 beats. That gives you adequate workload for most people.
Does it matter by age?
No. Obviously, the expected heart rate achieved, or the so-called maximum heart rate in older people, will be lower in older age group. So that's understood, and that's where I think the guidance of these professionals comes in, and that's why we like to start out in the program with phase 2. That's where you are being monitored. That's where you're being coached, and then they will set you free if you want to. And you can do it on your own, or be checked once a month at the most. And but I think that little guidance is necessary in the beginning, especially if you've had a heart attack or a significant heart problem. Now, people who want to do preventive exercise, they don't have any known heart problem, they don't need to go through our program necessarily. They're welcome to, but it's not as essential as for people who already have declared themselves having heart disease. There are no more questions. I really appreciate your attention, and we'll do it again next year.
Thank you.
Thank you. Thank you very much.
Thank you so much.
My pleasure.
Thank you.